we're ready to start the session. We've got, again, another packed session. What we're going to do is we're going to allow 4 speakers, then we're going to hold a question answer, and then we're going to have another 4 speakers, and myself and Kenneth will alternate in introducing the speakers. The first speaker is Rajni from the Vardhman Mahavir Medical College in India, and they're going to talk about fluoroquinolone resistance and Salmonelloses species. Okay. So we'll be fairly tight on time, so please try and stay to time. Thank you.
I'm going to talk about the burden of enteric fever from a tertiary care center in New Delhi, which is Safdarjung Hospital, which is affiliated to Ministry of Health, and it is a 1,800-bedded hospital situated in New Delhi and caters to the population not only of New Delhi but the adjoining areas of Haryana, UP, Uttar Pradesh, Punjab, and Rajasthan. It has a footfall of annual OPD attendance of around 15 lakhs and an admission rate of about 1.5 lakhs. This work which I'm going to present is a contribution from my PhD student and my resident Geeta Prohit and Ruchi Gupta. Sorry. Now coming to the burden in India, according to the National Health Profile of 2015, there were about 1.7 million cases of typhoid fever in India in 2014, and the total deaths reported were 429, according to the Integrated Disease Surveillance Program, which gets data from all the states all over India. Now, India being a subcontinent is a huge area. It has got a lot of diversity as far, both culturally and as far as the disease burden is concerned. Coming to the typhoid vaccine, the status, the typhoid vaccine was, typhoid and paratyphoid vaccine was introduced prior to 1981 in the extended program of immunization and then withdrawn in 1981 because of higher reactogenicity due to the vaccine, low efficacy, and the perceived, it was perceived that the reduced burden of typhoid cases in India during that time. Currently, I must mention here that health is a state subject in India, and being a huge geographical area with so many states, the vaccination policy is besides the universal program of immunization, the states have a say in introducing whatever vaccine they want additionally. So in New Delhi, where this data is being projected, the Delhi government has a policy to give free typhoid vaccination. So I'm going to present data from 2004 to 2013 of typhoid and paratyphoid, in which there were 1,266 cases of culture-positive cases. Our lab receives more than 80 blood culture samples per day. And I'm going to talk about the trends, seasonal distribution, clinical presentation, antibiogram pattern, and mechanism of fluoroquinolone resistance, and how these two serovars differ. So besides the 1,266 samples which we are going to talk about, we have done in a subset of 206 samples the mechanism of fluoroquinolone resistance. And if you look, this slide shows you the seasonal variation of typhoid and paratyphoid. And if you look at the blue graph, it shows you that distribution of typhoid, and it occurs in the months of summer and rainy season, that is from May to July, and the peaks of paratyphoid in red coincide with those of typhoid. So there is no difference. They occur at the same time, but the rates of paratyphoid are less. If you see between 2004, 5, and 6, you will find that peaks of typhoid have crossed in certain months beyond the number of cases of paratyphoid exceeded those of typhoid. And I feel this was a period of an extended outbreak of typhoid in Delhi. And after that, later if you see, always paratyphoid cases have been less than those of typhoid cases. This also coincides when there was sudden increase of fluoroquinolone resistance, that is, the emergence of nalidixic acid resistant strains in India. This could also be related to that, the increase in number of paratyphoid cases. If you look back to data from 1999 to 2004, again you will see that the number of cases of paratyphoid were much less than typhoid. It was only in the period of 2004 to 6 when we had paratyphoid exceeding typhoid. Over the years from 1999 to 2013, the overall ratio of typhoid to paratyphoid has been 4:1, except during the period 2004 to 6, and we have seen a drastic decrease in number of typhoid and paratyphoid cases over the years. Now, this could be attributed to the vaccination policy in Delhi. Secondly, this could be a biased data because it is a hospital-based data, it is not a community-based data. And thirdly, in recent last decade, Delhi has observed a lot of outbreaks of dengue and chikungunya, where, the patient presents with acute, undifferentiated fever, and when it is a dengue outbreak, the doctors don't actually screen patients for enteric fever. But surely there has been a fall in both typhoid and paratyphoid cases. Now, this shows you the ratio from 1999 to 2013. It was 4:1, approximately 5:1 in 1999. Came down, the number of paratyphoid cases increased, and in 2004, we had a ratio of 2.3:1. And again now, we have a ratio of about 6.4:1 now, currently. Now, coming to the age-related differences, now India is endemic for typhoid fever. And we treat, as Dr. Samir mentioned yesterday, in endemic countries, we treat all typhoid and enteric fever cases at the outpatient department. If we start admitting them, we won't have beds for anyone else. So if you look at this, the age difference, if you see the typhi is in blue, and paratyphoid is in red, the paratyphoid cases are more above 12 years of age. They are less in ages between 5 to 12 and less, even more less in children less than 5 years. This could tell you that the epidemiology of the two diseases may be different. And it has been mentioned in a few papers that probably paratyphoid is associated with solid food consumption, which starts when the child is when a 12-year child is more likely to go out and eat. And if children in the school age group, school-going age group, are more under supervision of the parents and they go out together. Now, coming to typhoid and paratyphoid, as I told you, we treat patients at the outpatient department. The number of admissions for typhi are much higher as compared to paratyphoid, which is around only 11 compared to around 200 for typhi. So this again indicates, because in India, the criteria for admission for enteric fever is either a complicated typhoid fever or a very young child where you have to give intravenous antibiotics. This again signifies a benign disease associated with paratyphoid. Now, coming to drug resistance in the two serotypes, I would just go through the definitions. We were using nalidixic acid as a surrogate marker for low-level fluoroquinolone resistance. And this was important because low-level fluoroquinolone resistance, it was perceived that, as Professor Parry said, that it determines the clinical outcomes. If you are infected with strains with low-level fluoroquinolone resistance, the defervescence period could be longer, and the clinician has to be told that he has to give treatment for a longer time. And these strains have to be differentiated from fluoroquinolone-resistant strains, which is high-level fluoroquinolone resistance. Now, if you look at Typhi and paratyphi ciprofloxacin MICs, the first one is Typhi, the first graph on the top. If you see, okay, I'll just finish it up. The Salmonella typhi has strains, nalidixic acid susceptible, which are seen as blue dots, blue graphs, with decreased ciprofloxacin susceptibility, and they are not detected by nalidixic acid DIS test. And it was at this period that CLSI revised the guidelines, and they revised the breakpoints for screening. Paratyphi, you have a distinct differentiation of nalidixic acid resistant strains, which are completely show complete decreased ciprofloxacin susceptibility. Now, among Typhi and paratyphi, nalidixic acid strains are more prevalent among paratyphi. They are 100% nalidixic acid resistance. And in Typhi, you have about 80% to 90% of them are nalidixic acid resistance. MDR is not observed in paratyphi, and high-level fluoroquinolone resistance is also not observed in paratyphi A. Now, regarding fluoroquinolone resistance, if you see that nalidixic acid MICs of paratyphi and Typhi, if you observe, you will find that even amongst the nalidixic acid susceptible strains, the MICs of paratyphi are 10-fold higher compared to the nalidixic acid susceptible strains of Typhi. It is inherently more resistant. The diversity of the genes which cause resistance to fluoroquinolones was more in Salmonella typhi, and we had a distinct phenotype which was nalidixic acid susceptible and having decreased susceptibility to fluoroquinolones in Salmonella typhi, which was not observed in paratyphi A. Yes, Al. Even with other antibiotics, I finished just the MICs of azithromycin and ceftriaxone were also 10-fold higher for ceftriaxone for paratyphi and 2-fold higher for azithromycin. Typhi is more heterogeneous and paratyphi is more homogeneous in its distribution. And conclusion, epidemiology and clinical presentation of typhoid and paratyphoid fever are distinct. Paratyphi A is declining and overall contributes to only approximately 20% of the enteric fever cases. Antibiotic resistance patterns are different, and primary drugs like ampicillin, chloramphenicol, and cotrimoxazole can still be used for paratyphi A. Thank you very much for the patient here.
Thank you very much. Very interesting, and thanks for keeping to time. Thank you very much.
Thank you, Rajni. Our next speaker is Pietro Mastroeni from the University of Cambridge, who will be speaking on the impact of antimicrobial treatment on pathogen behavior. Okay.
Good morning, everybody. Thank you for inviting me to this interesting conference. So, when we talk about antibiotic treatment, or when we implement antibiotic treatment, We would like to be in this ideal situation where the bacteria grow in the tissues of the host, they cause some symptoms, then we come in with antibiotic, clear the infection completely, and everybody lives happily ever after. Unfortunately, the real world is quite different, and there are quite complex scenarios and challenge to treatment and clearance. And difficulties in treatment, they're not only ascribed to antimicrobial resistance gene. Until now, we have talked a lot about antimicrobial resistance in this conference, but it's not just antimicrobial resistance. What happens if you treat a mouse or another animal with antibiotics? The bacteria grow, then you see that the bacterial load is reduced rapidly initially, but then bacteria persist in the in presence of further antibiotic treatment. When the antibiotic course is stopped, then if the animal is immunocompetent, the bacteria persist. If there are problems with the innate immune system, there is a quick relapse. If persistence occurs, it continues until T cells clear the infection. So the immune system helps antibiotics to clear the infection, and clearance is dependent on immunity, not just on antibiotics. So if an animal is deficient in T cells or has a particular MHC haplotype, the infection can relapse. And persistence is something very undesirable because it leads to transmission, to pathogen adaptation, like Chris said before, and like has been shown by my friend Elisabeth Clem in a recent publication. And if you look at what happens in the field, there are lots of comorbidities like malaria, anemia, worms, HIV, and malnutrition that actually can affect the immune system and give us problems even when the pathogen is antibiotic sensitive. And things are complex only when we don't know about them. And sometimes we think about antibiotic treatment in a slightly simplistic way. We have an antibiotic and we want to achieve cure. But we don't always take into consideration that there is a gray box of host versus pathogen behavior that contains many variables that can affect the efficacy of our treatment. And antimicrobial resistance is only one of these many variables. So we started looking at some of these variables. So we are just, scratching the surface, and in the future we're going to delve deeper into these matters. So we started looking at some traits of pathogen behavior that can affect the efficacy of treatment. So we looked at bacterial growth rates. We looked at spread in the body or compartmentalization in some organs and organ-specific behavior of the bacteria. If you infect experimental animals with a virulent strain of Salmonella typhimurium and then implement 4 days of ampicillin or cephalosporin treatment, what you see is that in the spleen and liver, there is an initial phase of rapid clearance, but then from day 3 onwards, and we could continue the antibiotic treatment if we wanted, but it's not necessary because we already reached a plateau here. So there is a phase of persistence. So there's a population of bacteria that is not cleared by the antibiotic. If you look in the mesenteric lymph nodes, there are bacteria, yes, but the bacterial load is not touched by the antibiotic treatment. There is no reduction whatsoever. As soon as we stop the antibiotic treatment, the infection relapses, even in the mesenteric lymph nodes where the bacteria were not affected by the treatment. So there are organ-specific behaviors of the bacteria that affect antibiotic treatment. What about growth rates? Here we compared the effect of 2 antibiotics on a fast-growing strain and a slow-growing aromatic-dependent mutant. As you can see, the aromatic-dependent mutant in the spleen and liver is affected a lot less by the antibiotic treatment as compared to the virulent bacteria. Again, in the mesenteric lymph nodes, in this privileged site, the bacterial load is not reduced by the antibiotics at all. The lack of efficacy of antibiotics in the mesenteric lymph nodes is quite puzzling. And it's more puzzling the fact that the bacteria relapse immediately at this site as soon as antibiotic treatment is removed. So we started asking the question, is the mesenteric lymph nodes really a compartmentalized site? Is it like a bag within the animal where the antibiotic doesn't get, where other bacteria don't get? Do the bacteria mix between organs? Can they access the mesenteric lymph nodes? And also, since the bacteria relapse, is the relapse endogenous from those bacterial populations that were not being killed, or is the relapse due to other bacteria that come into the mesenteric lymph nodes from other sites? Now, to address these questions, we used a method that whereby we infect animals with molecularly tagged bacterial populations. These are 8 subpopulations of the same Salmonella strain, each one containing a short molecular tag. The bacteria don't know that they have it, and these bacteria all have equal fitness. These bacteria are injected into an animal, then antibiotic treatment is implemented, then it's stopped, so we look at the relapse phase. At times after infection, we harvest the organs, we count the total bacterial load, but also by sequencing the tags, we can determine presence, absence, and relative proportions of each one of these bacterial populations. And this is how it looks. These are correlation plots. They look very difficult, but they're quite easy actually to interpret. I'll take you through this. What you're looking here is that the relative frequency of each one of the tagged bacteria in the liver versus the spleen. There are 8, so they would start here, all right in the middle spot at 12.5%. But normally, even before we start antibiotic treatment, there is stochastic selection of some amplification of some subpopulations. That's why you get this stretch. But if you look at this spread, it's all along the diagonal. That means that each one of the populations is in the identical percentage in the spleen and in the liver. What does this mean? This means that the spleen and the liver behave as a unique body compartment, where each population spreads freely and is in the same percentage in both organs. Antibiotic treatment doesn't change this. The relapse phase after antibiotic treatment doesn't affect it either. The fact that these populations of the diagonal, they don't condense in the middle or they don't spread, also tells us that the antibiotic is acting equally or similarly on the whole population load. So there is no preferential killing of some subpopulations of others, and the relapse is not due to a jackpot event where 1 or 2 populations amplify, escape the antibiotic or escape the immune system over others. What about the mesenteric lymph nodes, which is probably the most interesting bit? We looked at the correlation of these tagged populations in the mesenteric lymph nodes versus the spleen, and if we look versus the liver, we get exactly the same results. Here, the tagged populations are not on the diagonal. That means that the mesenteric lymph node has a different population structure from the spleen and the liver, not shown. So that means that the mesenteric lymph node, before the antibiotic treatment, throughout the antibiotic treatment, and later in the relapse phase, is a unique, separate compartment. And the relapse of the infection and this site is not due by a migration of bacteria from other organs. Interestingly, in this stage of the infection, we also have a relapse of bacteremia. So the bacteria that are in the blood, the same composition that we have in the blood is found in the spleen and liver, but it is different from the mesenteric lymph node. So again, bacteremia doesn't allow the movement of bacteria from the blood to to the mesenteric lymph node. So conclusions, yes, conclusion slide. So we conclude antibody-sensitive bacteria persist in the tissues despite treatment. Bacterial net growth rates do correlate with efficacy of treatment, and mesenteric lymph nodes are as a compartmentalized site where the bacteria are rather refractory to treatment. Now, we said we're going to delve deeper. It's a complex scenario, but as I said, things are complex only where we don't understand them. I do advocate that to improve our treatments and to make them more successful in terms of choice of antibiotics, non-compound strategies, formulations, delivery systems, and even new drugs, we really need to understand pathogen behavior in relation to the host. So we can do things rationally, sensibly, and move away from empirical approaches. 10 seconds late, sorry.
You're actually under time, so thank you very much. Perfect timing, thank you. Okay, so we have the next speaker, and this is Bhaskar Shenoy from Bangalore. Who's going to talk about hospital-based study and impact on antimicrobial resistance. Thank you very much.
Good afternoon. I am talking about the antibiograms of enteric fever in a tertiary care hospital in India. We all know the burden of disease, which has been spoken very well, and what is worrisome is the magnitude of the antimicrobial resistance, which one of the previous speakers has touched upon. This shows the distribution of the various types of resistances, including ESBLs among the S-types all over the globe. Since the introduction in 1948, chloramphenicol has been the treatment of choice, and then resistance developed, and we started using ampicillin and cotrimoxazole. And after 1980s, chlortrimoxazole also started developing resistance. Global burden varies with the region to region and country to country. Fluoroquinolones became the first line drug after the emergence of MDR strains. However, shortly the fluoroquinolone also started developing resistance, and it is found that the mortality and complications are higher in the MDR strains of Salmonella typhi and paratyphi and the fluoroquinolone resistant strains. And this emergence of MDR and other things has necessitated the use of newer antibiotics. High levels of multi-drug and fluoroquinolone resistance have made the cephalosporins as the drug of choice, especially in many places in South Asia. And azithromycin also started coming to the market and in the treatment of enteric fever. Shortly, the azithromycin resistant strains of typhi and paratyphi has been reported both from India, Pakistan, and Cambodia, and many other places. Recently, we have been seeing a shifting of the susceptibility of conventional drugs like chloramphenicol, ampicillin, and cotrimoxazole. With this background, we tried to analyze the antibiotic sensitivity pattern of culture-proven enteric fever and to evaluate the prevalence changing trends in the antibiotic resistance and the demographic profile. This is a retrospective study of 826 children between the age of 0 to 18 years at Bangalore, India, from November 2008 to 2006. We included the cases who had clinical signs and symptoms compatible with the enteric fever and those with a positive blood culture isolating Salmonella typhi or paratyphi. Those diagnoses were based only on clinical and serological grounds were excluded from the study. Blood culture and identification of the species was done by the standard methods. We used the Irby-Baer method for susceptibility testing. When it comes to azithromycin, initially BSCAC guidelines and now CLSI guidelines are being used. Out of total 826, 76.3% were Salmonella typhi and 23% of the cultures were Salmonella paratyphi. and the incidence was more with the age group of 2 to 10 years, and contributing to around 52%, and 38% were above 10 years. We looked at the vaccination status of these children who had enteric fever, and those vaccinated children, 43% got typhoid in spite of the vaccination. Mind you, this is not a conjugate vaccine. This was a polysaccharide vaccine. We looked at the sensitivity pattern, which is slowly raised from, for ampicillin, chloramphenicol, and cotrimoxazole from 2008, and now of late, last 2 years, it has been showing total 100% sensitivity. Now, what happened to the first-line drugs? The first-line ampicillin, about 98.6% overall, cotrimoxazole 97%, and chloramphenicol 98.6% with a significant p-value. MDR typhoid also started coming down. Almost last 2 years, it is not there. Age-wise distribution is shown here. The fate of the second-line drugs like fluoroquinolones. The nalidixic acid resistance was seen in more than 90% of the children, and ciprofloxacin sensitivity was in 64%, and about 30% were ciprofloxacin intermediate sensitivity was seen. This graph shows that. So the nalidixic acid resistance was 91.2%, ciprofloxacin resistance and intermediate totally together, it is 35.36%. The antibiotics of present days, which we have been routinely using, ceftriaxone and azithromycin, both were 100% sensitive, except for a small period, 2009 to 2010 and 11, we had 1 cases, so probably because of the change in the MICs. Distribution of the resistance, as I have already told, this shows the pooled percent sensitivity. So the prevalence of MDR typhoid is 1.45% when compared to the study done in the same geographical area, maybe in 1991 and 92, which showed 95%. That means it has come down from 95% to barely below 2%. MDR strains in our study was seen only in Salmonella typhi, and the rise in enteric fever due to paratyphi contributing to around 25%. Nalidixic acid resistance, correlation with ciprofloxacin resistance and intermittent resistance was poor. Ceftriaxone remains 100% sensitive. Azithromycin is still a viable alternative in most of the fluoroquinolone resistant strains. We compared the various studies available all over the globe, especially in the developing countries. Indian studies also showed the similar results, but Iraq, Egypt, Uganda, and Pakistan showed a quite a high prevalence of MDR typhoid. So to conclude, the incidence of MDR typhoid has drastically reduced over the years in our geographical area. The sensitivity to first-line drugs has come back, and Salmonella typhi and paratyphi still remain fully sensitive to ceftriaxone and azithromycin in our study. Ceftriaxone should be reserved for MDR typhoid cases because of the fear of developing resistance anytime, then we are not left with any drug in our armamentarium. And non-responsiveness to first-line drugs also, it can be reserved. Azithromycin, because there are stray reports of developing resistance, we should keep it as a reserve drug, and indiscriminate use of drugs leading to drug resistance has to be curbed. It is necessary to perform a regular survey of local antibiogram patterns, because that will help us to formulate the guidelines for the locally. And re-emergence of sensitivity to first-line drugs, probably whether a boon or bane, because it's a cost-effective and it can be given orally and increases the compliance. But there are fear of developing resistance when we introduce these drugs again. Better surrogate markers like p-floxacin can be used for assessing the fluoroquinolone resistance. There have been a lot of papers on that. development of bivalent and conjugate typhoid vaccine is should be a high priority, especially in a developing country. And vaccination of children, including less than 2 years, has to be strengthened, because in our study, around 10% of these children were below 2 years. So the limitations were there. It was a hospital-based study, because only the severe cases, probably those with the multi-drug resistant strains, only were taken into consideration. It was a single center study. Probably we need a larger multi-centric studies. The correlation with the clinical course and the severity we have not looked at, and genetic studies not done. I thank my institution for giving me an opportunity to conduct this study, and thank one and all. Thank you.
Thank you, Bhaskar. So we'll take one more speaker, and then we open up for questions. The next speaker is Andrea Parisi from the Australian National University, who will talk about drug resistance in high-income countries.
Good morning, everyone. Thank you for attending my presentation. So, as you can see, I have slightly different topic. It's non-typhoid salmonella, non-typhoid. So I will start with a little bit of epidemiological background. Non-typhoid salmonella causes approximately 153 million cases globally. 53% of these cases are said to be foodborne, and they result in almost 57,000 deaths. When we look at invasive non-typhoid salmonella infections, there are approximately 600,000 cases globally with 63,000 deaths. Because of globally rising antimicrobial resistance of non-typhoid salmonella infections, WHO included salmonella on their list of priority pathogens for new antimicrobials. Calculations based on estimates of the annual infection rates and attributable fractions of infections with non-typhoid salmonella suggest that resistance to antimicrobial agents results annually in additional 36,000 infections, more than 400 hospitalizations, and 12 deaths. This study was conducted in the USA. So basically, we had two aims in our meta-analysis and systematic review. First was to describe what data exist on health outcomes for multi-drug resistant and susceptible non-typhoid salmonella infections, and also see whether these health outcomes somehow differ between both groups. Our study was conducted only in our systematic review was conducted only in high-income countries, because we wanted to minimize differences in healthcare delivery, treatment options, and underlying resources. So our research methodology was conducted according to PRISMA guidelines, which are preferred reported items for systematic review and meta-analysis. And so according to these guidelines, we looked through scientific databases such as Medline, PubMed, Scopus, Web of Science, Cochrane Library, also a great literature, FDA, CDC, WHO library, and we also looked through the references of eligible studies. Because before we started systematic review, we did pre-research to see how many studies there will be available, and it looked like there are not many. So we had a very broad key strategy, search strategy, which included many keywords. I'm just showing you the primary search terms, but there were much more, and they were tailored specifically for each database. So I already mentioned that the analysis was only for studies conducted in high-income countries, as classified by World Bank using the ATLAS method. These also other eligible criteria was studies had to be published between 1st January 1990 and 15 September 2016, when our search was done. And the most importantly, the study had to report on health outcomes both in multi-drug resistant and TS salmonella, which we use definition of ECDC as non-susceptible to at least one agent in 3 or more antimicrobial classes, and susceptible NTS isolates, which you can see the list Okay, you can see the list. You can see the list here, which was at least all studies had to meet at least these criteria. Most of them, they had more testing available, but this was the absolute necessary limit. Our outcome measure was pooled odds ratio. We used 3 different meta-analytical models: inverse variance heterogeneity model, random effect model, and quality effect model. We did also quality assessment, which we included in quality effect model. And I'm going to present only inverse variance heterogeneity model because the results were quite similar, and I believe you're not interested in statistics. So, study selection. It's totally wrong. I don't know what happened. Okay. Actually, it's fine. No. Okay, never mind. So, we started with more than 7,000 articles, which after duplicates were removed, we had more than 4,000. After the screening of available abstracts, we ended up with 312 studies. Of these, we excluded more than almost 300. We ended up with 18. After duplicate data were removed, we ended up with 16. And at the end, out of more than 7,000 studies we screened, we ended up with 9 studies, which were included meta-analysis, which was quite frustrating. But we were able to meta-analyze 3 health outcomes, which was bloodstream infection, mortality, and hospitalization. Unfortunately, for length of hospital stay, we were not able to meta-analyze our results because we had missing information on standard deviation. But I will tell you the results, nevertheless, in the end, also for this health outcome. So the studies included in our meta-analysis, there were 9, I already mentioned. They were all from the United States. Other studies from Taiwan and Denmark, which were big studies, unfortunately didn't meet our last criteria. Also, we had 4 case control studies, 4 cohort studies, and 1 outbreak analysis. All studies covered more than 55 years of surveillance research with more than 78,000 participants. As you can see, because all studies were from the USA, there were common Salmonella serotypes such as Typhimurium, Enteroteris, Heidelberg, Newport. And antimicrobial resistance pattern was mostly penta-resistant AC as a COT. Now, results of our first meta-analysis for bloodstream infection. So you can see there are 6 studies. I will rapidly describe first, but I'm sure you're all familiar with it. So the squares represent the odds ratio of each single study. The bigger the square, the bigger weight of the study. The horizontal line represents confidence interval, and the diamond down on the bottom represents the pooled odds ratio. So you can see the result was quite significant. Bloodstream infections, patients with multi-drug-resistant infections had high risk of having bloodstream infection. Concerning hospitalization, we had 1 more study, so 7 studies in total. Also a result significant, 2.51, a little bit broader odds ratio in this case, a little bit broader confidence interval. And concerning mortality, we unfortunately had only 3 studies, and you can see 95% confidence interval here is very broad. It was due to the fact that there were differences in the numbers of participants in each of the compared groups and very little number of deaths. So slightly differences had very big effect on final odds ratio. Now, I wonder, well, everybody's probably asking the question, why have multi-drug-resistant NTS infections more severe outcomes? So there are several possible explanations. The initial therapy might be ineffective. There might be a need to choose less desirable drug, which might have more side effects, and there might be a linkage of virulence and resistant genes. This contransfer of virulence and resistant genes would make eventually resistant pathogen more virulent, and this would result in reduction of infection dose, or for a given infection dose, higher fatality rate. There might be a role of host factors, because we all know that children under the age of 5 and older adults are in high risk of acquiring invasive disease, and also there is underlying immunosuppressive conditions and comorbidities are associated with worse health outcomes. There might be a role of serotype. It's been already mentioned that not all serotypes are same virulent. There are some which are more virulent, like Heidelberg and Dublin. Even though we followed a comprehensive search strategy, there are several limitations. I already mentioned one, that all studies were from the United States. There are potential major confounders because not many studies reported on host factors and comorbidities which are known to increase the risk to invasive disease, so major potential confounder may be unmeasured. We were not also able to do any sub-meta-analysis that would look at specific serotypes. There is a limitation of assessment of bacteremia and possible publication bias. Now, conclusions. If our analysis is correct, multi-drug-resistant infections, non-typhoid or salmonella infections are linked with worse health outcomes. But also, our analysis presents the need for more adequately designed studies which would address potential confounders, which would look at more broadly description of health outcomes, and which would also look at specific antimicrobial patterns, not just those that I included. And of course, restrict the use of antimicrobials both in animals and humans. I would like to acknowledge my team, especially John Cram, who provided comments and suggestions, and all authors who provided additional information upon request. And I would like to thank you all for the attention, and I would like to take this opportunity that I can talk to all of you at one moment. And if somebody is staying after the conference some days and would like to join me on a safari trip starting on 7th of April, I would be very happy, not going alone. I have some travel companions, so if you're interested, just join me and I will give you more information. Thank you.
It's very, very well done. So the actual speakers are all fantastic in keeping perfectly to time, so it gives us a chance for some discussion. So anybody who wants to participate in discussion, feel free to do so.
Just wanted to bring up the issue of terminology, which I think is very familiar to all of the people working in typhoid when we talk about first-line antibiotics and MDR. But it was clear at dinner last night that not everyone is completely familiar with what that means, and it does result in some confusion about what we're saying in this meeting about drug resistance. And Gordon, you may want to say something about the acquisition of resistance in typhoid. But it's clear that this is an organism which is very capable of becoming resistant to whatever we throw at it. And for those who are not familiar with the terminology, first line actually means the first line drugs that we used to use frequently, which is the cotrimoxazole, chloramphenicol, and ampicillin. And so that's what we mean by first line, but that's actually not what's largely being used as first line these days. So that's the first point of confusion. And the other is that we mix up the word MDR with antimicrobial resistance. So when we say MDR is going away, so in other words, resistant to those first line drugs, what we don't mean is that antimicrobial resistance is going away. And I think that message has got a bit confused in the way that we present, because we're using terminology that we understand, but the rest of the world doesn't. So I think we just have to be very careful to be clear what we mean in typhoid, that antimicrobial resistance remains a problem today.
Okay, rather than me answer that, I think let's get some participation. So if anybody on the panel wants to make a comment, or the co-chair, and then we'll go on to the next question. I could come back to this maybe at the end of the session. Any comments from the panel members, or do you want to ask another question, Rob, whichever way you want to do this.
So this is in some way related to Andy's question and related to the last speaker. You analysed in relation to multi-drug resistance, but did you also analyse in relation to any resistance? So did any resistance impact on mortality?
No. Hello? Yes. No, unfortunately, in our analysis, we only look at matrix resistance as it was because there were very few studies, and in general, it was very hard to identify, and actually, even for a bloodstream infection, our extraction is a little bit questionable. But most of the studies, they didn't report on clinically important agent or 2 or more resistance. They generally reported on separate different classes of antimicrobials, and then they reported on matrix resistance. The reason why we did matrix resistance is because it was part of the study for Australian health agriculture study, which was looking at risk of importance of beef from high-income countries towards Australia. So, and the establishment of Salmonella DT104. So we were specifically asked to look only on MDR, specifically this penta-resistance ACSSUT, which is typical for DT104. So no, we didn't, but it's definitely planned for the future, and we also want to do same meta-analysis for typhoid. Thank you.
Pietro, just coming to your nice results from your model, and this lack of clearance of the Salmonella bacteria with antibiotics. It's something that we've wondered about a lot in humans as well, what's happening, and whether what we're seeing is a persistent latent state of infection occurring that can then be reactivated later on by alterations in host immunity. Would you like to just speculate on how the results that you're finding in the mouse might translate across to what's happening in humans?
Thanks for the question. Before I answer your question, I forgot. Before I answer your question, I forgot to acknowledge, because the time was short, the funders of that work, which is BBSRC UK, and the people who actually did the work, which is Dr. Omar Rossi, my wonderful postdoc, and Oliver Recife and Richard Dubosky, which are my wonderful mathematical modelers. To answer your question, Carl, from what I hear from you and the other clinical colleagues, relapses of salmonella infections, they are very common in HIV patients. They are very common in patients with genetic immunodeficiencies. And from work of Cinerio Coro, and Elizabeth did also some work, these are not reinfections, they are endogenous infections. Melita also did some work showing different intracellular numbers in the relapse phase than the previous, than in the initial infection. So there is a bulk of literature there in humans that points towards endogenous relapse, even multiple relapse incidents after antibiotic treatment. So in humans, there must be populations there that persist. Where they persist, I don't know. In the mouse, we find persistence in the spleen, in the liver, and in the mesenteric lymph nodes. We don't know yet which cells these bacteria are, what they do to these cells, to be able to persist, whether they evade the immune system. There is some evidence for bacteria with low replication rates and even dormant bacteria from Sophia Lane. So the matter is complicated and needs looking into quite carefully. That's why the last slide that I said we need really to study pathogen behavior in relation with the immune system under antimicrobial pressure to be able to understand this. But the parallel with the human situation, from what I hear from my clinical colleagues, is quite striking.
Thank you.
Well, there's a quick one.
Yeah, just really to fill in on what Piero was saying there. So in that work that Piero was referring to, we were able to find that the bacteria was intracellular in the bone marrow, and that by the time people came back with a recurrence, the load had increased significantly. So that was sort of strong circumstantial evidence for intracellular tissue persistence. We couldn't get at lymph nodes or other sites. And I think the other thing that we observed within an acute infection, it wasn't intracellular, but at the point where they relapsed, it was. And again, that suggested a kind of intracellular overspill from tissue sites back into the blood. So it does correlate very strikingly with your animal findings. Thanks.
Yes, Melita. Sorry.
No, I think we need to move on. We can go. Can you just wait till the end of the session, Mike? Or, yeah. So we'll move on because we're sticking to time. We will have more time at the end of the session then to actually progress those. Next speaker. Do you want to introduce that?
So our next speaker is Sam Kariuki from Cambridge, who will be talking to us about non-typhoidal Salmonella hotspots.
Thank you very much. I wish to share with you some early results from an ongoing study which we're doing in one of the slum areas east of Nairobi. And what we're doing is to try and map hotspots for disease, both NTS and typhoid, with a view to advising policy, especially for vaccination. So just as background, we've had lots of information about invasive NTS globally. In Kenya, of course, NTS, especially invasive NTS, are of great public importance, especially in poor resource settings. These are mainly the informal settlements where clean water supply, sanitation are really a challenge. So you find that invasive NTS, especially in children, are quite closely associated with anemia, malnutrition, malaria, and also HIV. But quite often you find also high incidence of invasive NTS, even in children who do not have some of these comorbidities. The epidemiology, transmission dynamics, and spatial geographic distribution of these infections, these are critical information that we require for purposes of monitoring, but then they're not well known. So in our study, this was the hypothesis that there exist unique genotypes of invasive NTS hotspots that cause disease in children perpetuated by specific host and environmental factors. So what we did was to set up a 5-year study, population-based surveillance for invasive disease in children less than 16 years of age. And this was mainly to capture both typhoid and NTS disease. And secondly, then we wanted to describe the spatial and spatio-temporal clustering in terms of genotypes to household level. So the study site is about 25 kilometers east of Nairobi. It's one of the largest slum areas after Kibera. The Kenya National Bureau of Statistics estimated about 250,000 in a very, very small area. Very high, densely populated area, very high levels of poverty. These are people coming from the rural areas, coming to work in the industrial areas, and with very little income. Of course, they look for what is affordable in terms of housing. So this typical of what you'd find in some of these very, very informal settlements. In fact, all these areas were government land aimed at building industries, but then, of course, people just squatting in, and then it's very, very difficult now to move them out at this stage. So what we did then was to recruit outpatients coming to any of the 4 outpatient clinics in that study site, less than 16 years of age, of course, with a history of fever, 3 days, temperature that's 7.5 or more, and then with or without diarrhea in the last 24 hours. And then we also had age-matched controls from children from the same clinic who came in for routine vaccination. Laboratory procedures, just the typical blood cultures, 1 to 3 ml for children, less than 5 years of age, and 5 to 10 ml for older children. And we did on-site HIV testing, and also saved blood on protein for protein analysis at a later stage, and also performed stool cultures in the very typical manner of microbiology. We are currently performing whole genome sequencing for all NTS and also Salmonella typhi, also in the same study, a total of over 500 isolates. And what we're doing also is to map these serotypes back to the DSS site and to correlate these genotypes and serotypes with environmental and socio-demographic factors with a view to associating risk factors for high occurrence of NTS, especially invasive disease. So these are the results. So far, we have censored 35 households in this region. And we have also obtained socioeconomic data from over 2,500 households, another 970 from another village. So in total, we have censored 4 villages in this large informal settlement and obtained socioeconomic data and information concerning health-seeking behavior. So this is the patient profile, number of patients recruited versus the cases versus the controls. Wherever possible, we had at least 1 case to 1 control that was age-matched. A typical day at any of the 4 clinical sites, very, very busy, because this is a highly densely populated area with sometimes imported malaria, and then therefore, of course, kids will show up with fever, which really sometimes does not distinguish between INTS or invasive disease and malaria. So these are the results for Salmonella positive samples from blood in blue, and then from stool cultures in green. And this mainly, whenever we took blood, we took also a stool specimen just to see the transition between enteric disease and invasive disease. And then, of course, the light blue isolates from controls. Very, very high courage rates, up to sometimes 10% of courage of NTS strains in this region. This is the map of the area, and we've mapped back both NTS in red, and the size of the dots corresponds directly to the total numbers observed in a specific area. And what we have observed, and the blue is for Salmonella typhi, what we have observed is that, especially for INTS, these are specific village areas or regions where we have water around or vendors around that area, very, very high concentration of vendors. Also kiosks that sell foods around, and you find that very close association. And then also close to some of the health seeking, some of the health centers that we were sampling. So those are some of the factors that we found very closely related to high concentration of the cases. Again, as discussed earlier, you find a lot of cases in the early ages of between 0 and 5 years of age, And then the number of cases, the prevalence reduces drastically at the age of 16. Much more NTS in the younger children below 3 years of age. And this is the resistance patterns to various antimicrobials. We are very, very fortunate that the level of resistance to fluoroquinolones is still fairly low, about 3%. But then we find a higher proportion, about 15%, with the reduced susceptibility to fluoroquinolones. We have recently observed in the last 3 years a rising proportion of INTs that are resistant to ceftriaxone. And this is very worrying because this is on a large mobile genetic element and easily transmissible also to typhi and other gram-negatives. No difference in terms of the profiles of antibiotic resistance patterns for Salmonella enteritis, which is the second largest cause of invasive disease in this Salam region. So in conclusion, this is a high-density populated area with endemic enteric disease and also very high incidence of invasive NTS. And we've been able to map hotspots of both typhi and Salmonella typhimurium enteritis to some of these risk factors, including water veining points and closeness to health care centers, among other issues, especially also surface water and surface sewage points. Rates of multi-drug resistance, very, very high for both serotypes. And these are areas or regions or hotspots that we could consider for any planned vaccine intervention. So this is work again through collaboration of many groups, including colleagues from KEMRI, from the Aga Khan Hospital in Nairobi, and our colleagues from the Sanger Institute and University of Cambridge, with funding from the Wellcome Trust and NIH. Thank you very much.
Thank you very much, Sam. Very nice presentation. We'll come back to that later on in the discussion. Now moving on to Satheesh Nair, who is from Public Health England, and will be talking really about how whole genome sequencing is impacting on epidemiological studies in the UK.
Good morning, everyone. I would like to thank the organizers for giving me a chance to speak at this conference. So what I'm going to do here in the next few minutes is basically talk about, or give you guys a flavor of how WGS has revolutionized public health microbiology in the UK. The classification of Salmonella is complicated. I mean, there's 2,600 different serovars, and the function of Public Health England is basically we do the identification, typing, and surveillance work of all Salmonellas that come through the UK. Pre-WGS, the identification methods were by real-time PCR, phenotypic microarrays by biolog, and the classical serotyping. But what I would like to stress is that currently we only do about 15 to 20% of this work in Public Health England. Classical typing methods like FARCH typing, MLVA, pulse field gel electrophoresis are basically obsolete now. Since 2010, we've basically explored the use of MLST for identification of Salmonella. And in general, what we found out was that we could define clusters. We could basically get clusters defined by MLSTs, and they correspond very well on a one-to-one basis with the different serovars. Since 2012, WGS has been implemented in Public Health England. The first 2-3 years of it was basically the time where we spent trying to develop the technique, and as you know, it's quite complicated. The investment for new machines and for the infrastructure, computational infrastructure. The reason why Salmonella was chosen as the priority organism in 2013 was because of the high burden. We see about 10,000 cases a year, and also the ability of MLST to identify Salmonella. Okay, just a quick schematic representation. Samples arrive, we basically extract the genomic DNA, high throughput genomic extractions, we quantify it, we then submit it to the genomic service unit, and all the sequence data then is automatically transferred to the bioinformatics department. And the sequence data is then channeled to our Salmonella reference service bioinformaticians. And they have basically come up with something that's called the Salmonella Gastro Robot, which is basically a warehouse of data that is linked to all the different pipelines. And for instance, here you have the sequence typing data that is linked to Mark Axman's MLST database. You've got the in silico sex0 antigenic structures, which is basically designed by Deng and all in the States. We can identify monophasic typhimuriums, and then we have got our own antibiotic resistance pipeline, and also we have got what we call our SNP databases for surveillance. And then all that data is basically channeled to our MOLIS warehouse, where we use it for our technical and medical validation, and then we report it out to our customers. So since the 1st of April 2015, WGS has been adopted routinely in our institution. Basically, the first thing was for using it for identification, to replace all the lengthy laboratory methods, and also to provide identification and typing in a single method. So this is basically what happens with our reports nowadays. They come back in an automated form. Here you have, sorry I can't point it in both sides, but the first column is basically our strains. Second column basically tells you the MLST profiles. We've got the, what do you call this, a validation, the quality control, sorry. And then it basically identifies the last column, it identifies the serovar. For example, the last one is ST413, and it says Salmonella bandaka. And this is basically a snapshot of about 8,000 salmonellas that have come through our lab in 1 year. And just looking at it, it basically tells you the population structure of all the different salmonellas that come through the UK. One look at it, and you can tell from the large green circle that Enteritidis is the most common serovar in the UK. You've got the brown circles there, Typhimurium, and you see typhes at the bottom there. Sorry, I don't have time to go into detail, but basically 50% of our typhes are basically the H58s. We have basically also used WGS to develop our own gene finder, an antimicrobial resistance finder developed by Michel Dumet. It basically, the database has about 1,600 known resistance genes. The interesting thing is the yellow column there, column that you see is basically all the different classes of antibiotics. The first column again is the strain, and immediately once it's channeled through the pipeline, it picks up all the antimicrobial resistance genes and it gives you a resistance profile. And what we've basically found is that there's only 1% error between the prediction of genotypic resistance versus phenotypic resistance. Okay, then we also use WGS for our typing, for detecting, doing higher resolution SNP typing for surveillance and outbreaks. Our bioinformaticians have created what they call a SNP database of the top 14 serovars that we see in the UK, which is 90% of our workload. And the interesting thing about this database is basically once a strain is sequenced, and if it belongs in one of the serovars, immediately the sequence data then is generated into a phylogenetic tree, and then you basically can tell whether it's an outbreak strain or whichever clade that it comes from. And basically by using this data, we were able to solve a national and international outbreak of Salmonella enteritidis 14B in 2014. It started in the UK at the bottom there in a hospital, and then we realized from some of our European colleagues who sent us out their strains, And basically what they did was, it's only a 10 SNP difference between all the strains in that tree, and they basically were able to trace it back to a hatchery in Germany, and that particular company was basically prosecuted, showing how powerful the technique is, that we could even use it for court evidence. And this is probably the most interesting part of my talk, is detection of novel regions, giving you an example of azithromycin in Salmonella blockleaf. Acquired resistance to macrolides come in different mechanisms, but I just want you to focus on the MPHA. In Enterobacteriaceae, presence of MPHA is sufficient to cause high resistance. And the worrying thing is that azithromycin now is being used to treat enteric fever and invasive diseases in certain countries. Macrolide, during our gene finder validation, we found out that there were quite a number of our Salmonella blockleaf strains that had the presence of MPHA gene. And these strains were highly drug resistant. They had MIC higher of 16 milligrams per mil. And so I basically asked the question, were they chromosomally or plasmid mediated? So we used Illumina sequencing basically to describe the structure of the island. Unfortunately, Illumina sequencing doesn't give you the whole structure because it short reads. And so we predicted that structure. We submitted it to Journal of Antimicrobial Chemotherapy. They wrote back and said, in this day and age, you've got many different sequencing methods that will be able to, that should enable you to answer the question. So what we basically did was MinION sequencing that gave us longer reads. And what we did was a hybrid assembly between the Illumina sequencing, the short read, and the longer reads of MinION sequencing. And based on that, we were able to piece up the whole island. And the interesting thing was we basically described the first chromosomally mediated macrolide drug resistant in Salmonella. We called it SARGI. And the little yellow line that you see, it's the MPHA. It's a cluster that's very, very promiscuous. And that is the cluster that's hopping into all different Salmonellas. The other important finding from this study is that azithromycin is found not only in blockleaf, but in multiple serovars, 14 different serovars that were found in the UK. And the dreadful thing is that it's found both on the chromosome and on the plasmid. And every single drug-resistant island is novel. We're characterizing it right now. And the island range from 16 kb to 80 kb in Salmonella Stanley that has got nearly every antimicrobial resistance that you can think of. I'm almost ending. Sorry, and this is a surveillance of emerging virulent pathogens, and thank goodness Nick Feasey mentioned this yesterday, so I don't have to go in detail. We do see ST313 in the UK, but the interesting thing is that we see a separate lineage compared to the African ones, and these are only associated to gastroenteritis. And the interesting thing about our lineage is that they are fully sensitive, fully black, which is in the middle, compared to the two African lineages. Anybody wants to talk to me about this, we can do it later on. General conclusions, rapid evolution of sequencing technologies helps for high throughput identification, typing of bacteria, identification of virulence of drug resistance. But the most important thing is that it allows the development of simple tools that we can take out to the field, fields where there's no sequencing technology. And currently we have developed a PCR-based assay to differentiate between the enterics and the NTSs, real-time PCR to differentiate drug resistance. And if anybody needs to talk about this, we can do it later. And the other important thing is that all our sequences are stored in the NCBI Genome Tracker project. Thank you.
Thank you.
Good afternoon. So I'm making this presentation on behalf of my colleague who was unable to make it. And it's basically looking at the effect of using antibiotics before going to the healthcare facility. and its relation to, in this case, S. typhi, INTS, and other pathogens. I think as we all know, most of us commonly use antibiotics, and I'm sure most of us even inside here, we are culprits, either before going to the healthcare facility or even before the doctor can make a final diagnosis for other reasons. And this is a sub-analysis from the Typhoid Surveillance African Project that was done in 2010 to 2014, and I'll delve into that in a little bit. And the analysis here was to look at the effect of antibiotic usage before going to the healthcare facility, in this particular case, the study site facilities, and its effect on blood culture results on the infections, either caused by S. typhi, in Typhoid or Salmonella, and other bacterial infections. I'm sure this has been talked very much by my other colleagues, but TSAP took place from 2010 to 2014. It was in 10 countries, about 13 sites, in which about 21,000 patients were enrolled. And from each patient, there was a blood culture done on them. And what I'm going to talk about here will be limited to those who reported usage of antibiotics, as I'll show in the next slides. Overall, of the patients who were enrolled, about 4% had a positive blood culture, and of this, combined for S. typhi and INTS, we had 39.1% who were positive by blood culture. This specifically looks at those who reported using antibiotics before going to the healthcare facility. And maybe it is important to note here that the usage of antibiotics before going to the healthcare facility is limited to the report of the patient, and that is before they went to the healthcare facility, which is where the study was taking place. And about 11% of the patients did report usage of antibiotics before going to the healthcare facility. And out of this, among those who had a blood culture done, of those who were reported using antibiotics, about 4.26% were from other bacterial pathogens, then 1.6 for S. typhi, and about 0.6 was INTS. And when you try to look between S. typhi for those who reported using antibiotics and for those who did not, at least it's slightly higher. And basically that leads me to what my colleague was interested in, was basically try to compare among those S. typhi patients who did take antibiotics or who did report using antibiotics as compared to those with other bloodstream infections, excluding INTS here. And one has twice as much chance of having a blood culture positive, irrespective of having reported using antibiotics. And the results basically similar even when you look at S. typhi patients in general to those who reported fever. It's also significant. No, just go back. Sorry. But however, when you look at INTS, there was no difference between INTS and other bloodstream infection. And equally the same was when you're trying to look at it in relation to those who had a fever, which raises very interesting maybe points, because when you try to look at for S. typhi, there was a significant difference, but in this case not. One might want to opine probably maybe the role of like for instance MDR, but I think if that's something like that would have been possible, then you will want to have seen consistent results between S. typhi and INTS. But again, it goes further than to see that this analysis had several limitations, because you were relying on what the patient told you, and the patient might have not really known whether they were having, they have taken an antibiotic or something else, and this was what they either purchased or before they went to the healthcare facility. And which then definitely leads me to the limitation that, as I've said, we were relying on self-reporting by the patient, and we don't know what antibiotics were taken. And then of the antibiotics, we don't know the duration and even for how long they'd been able to take it. before they went to the healthcare facility. And information about like antimicrobial testing, which could have been more specific, is not available. Which then takes me to the summaries of it. Is like, it's likely probably those who had typhoid were exhibiting severe symptoms, but that's the far one can go, not very certain. And then those who had invasive salmonella or with the other bacterial pathogens. But then this is just there. It's more open to more discussion given the limitations that are there. But I think when you look at those considerations, then it was not fully, one could not be able to fully assess to what degree antibiotic usage before going to the healthcare facilities did affect the blood culture findings. And the likelihood of MDR resistance in relation to S. typhi being a culprit, that is also another possible point of discussion. I think with that, that's the summary I could be able to put together. And basically, most of these are the guys who were involved in TSAP when it began, and by virtue of the fact that they contributed the data, I'm grateful to them, and definitely to BMG for the funding.
Thank you very much. Very well done. Okay, so we're now in good shape to have a discussion. I do encourage people who have not been to the podium, who have got, don't be shy, go over there and ask a question if you've not been there. But let's get on with it, and feel free to answer any questions you feel you would like to put to the panel.
This is a question for Dr. Kariuki. I'm curious about differences in antimicrobial resistance profiles between the isolates you were isolated from the invasive versus the diarrheal patients, whether you observed any, and if you have any plans to genotype those strains.
I hope I can be heard. Yeah, thank you. Thanks for that question. So far for the analysis we have done, we have not seen any significant difference between the actual phenotypes of enteric isolates versus the invasive isolates, especially on antibiotic resistance patterns. As I said, we sequencing close to 550 isolates of them, so we'll be able to probably mine more details from the whole genome sequence data.
Hiroki, if you go next, and then Andy.
Thank you. Thanks for some great talks. I have two very quick questions. First is for Sam. If your study is population-based, what explains the hotspots around health facilities? And then the second question is actually for Sandra. Two of the resistance genes that were in your 2B lineage were DFRA7 and SOL2. And we'd found a plasmid circulating in commensal populations in West Africa and elsewhere. And we're just wondering what the context of those genes was and whether that's actually a transposon, whether that transposon had moved into NTS. Thanks.
Thanks very much, Iruka, for your question. We still in the stages of analysis. This is quite preliminary, but I tend to think probably this is fairly coincidental, and that there are many other factors that are associated with intensity around two of the 4 health centers. It's very, very likely there are more factors than that. But I think this is one study we're hoping that will point towards where we can really concentrate our efforts on vaccination.
Yes, thank you. The resistance that we found in our sublineage 2B was present on a large plasmid, this CST 313 plasmid, and it was all present in one large cassette. We looked for similarities of this full plasmid within public databases, and it was mostly similar to a plasmid that was previously being found in Serratia, but also showed quite some similarity to the plasmid that the group of San Kariuki reported, PKSA 313. But it definitely, well, it's mostly based on the backbone of the plasmid, but it would definitely be interesting also to look at the cassette itself and to see how similar it is to other cassettes.
Thank you.
I just wanted to bring up one issue that there is about self-reporting of antibiotic use, which we discovered in Nepal, where we looked at about 2,000 children and used a very similar approach to the one that you have. And what we then did is we looked at those who said they didn't take antibiotics and tested the urine for antibiotic activity. And about a third of those children whose parents said they hadn't used antibiotics did have antibiotic activity in the urine. And so I wonder how that might influence results in studies like this, given that self-reporting it may not be entirely reliable.
Thank you. Thank you for that, and we hope that as a follow-up to TSAP, now we are doing CETA, beyond people giving information about use of antibiotics before coming to the healthcare facility. We will also be testing the presence of the same, and I think probably that can be able to give a more specific look and comparison between before and after. Thank you.
Thank you. Just to add an additional comment to that, so we've been looking at antibiotic use pre-treatment in patients in Cambodia and in Laos and in Manila. And testing all patients with a urine test, with a bioassay plus the history. And the thing I found interesting was that actually the discrepancy between reporting and antibiotic use in urine was different between the two sites. So there was a big discrepancy in Cambodia, 70% reporting antibiotic use, but only 30% confirmed by urinary antibiotic activity. Whereas in Manila, actually, the concordance was very close, and people did seem to report accurately. Mm-hmm. The second point is that antibiotic use is interesting, but in a way, what we'd really like to know is which antibiotic, because in relation to typhoid with multi-drug resistant strains, we'd like to know what people are using, and we've been trying to modify the bioassay to maybe pick up more the use of more extended spectrum antibiotics, but the methodology isn't quite there yet.
Probably, I think I'll want to follow up with you after on the fast, because it's interesting to see that at least you've got two sites with different reporting rates. Maybe it also might be good to know how different these site profiles are. What might have been contributing that on one side people are reporting very accurately and on the other differently.
Can I ask, Sandra, it was difficult to see from your trees, but did the two subclades emerge simultaneously, or are they concurrent introductions into DRC? How do you think the two subclades emerged?
So we found the lineage 1 and the lineage 2. We just described them based on the sequences from Okoro, and all are resistant strains, so that were MDR and showed the ASBL positive phenotype and azithromycin resistance. These strains took up this sublineage 2B. The controls, I haven't pointed out in the figure, they all fell in this lineage 2 that was already present at other places on the continent. I hope that makes it clear, or
not quite, but perhaps we can discuss it later.
I can show you the figure again, and then it's probably easier.
Melissa?
Sorry, just to sort of toss something into the antimicrobial testing. So when we did this with adults in Malawi, when we were doing quantitative cultures, there was quite high self-reporting, and we found almost no activity in the urine. So
I think we should change the raffle. What we should do is give a prize to somebody who hasn't asked a question before. Maybe $10. That might get a few hundred people up. But $10 to the next person who's not asked a question from
I'll take your $10.
It will be not by me. Cat are going to donate this. They're not listening, so I've just awarded you $10, right?
So, hello, my name is Scott Balaban from the Center for Vaccine Development. I just have a quick question for Pietro. I was wondering if you could speculate what makes the MLN compartment unique from the spleen and liver.
The simple answer is I have no idea yet. Okay. It could be likely that the bacteria have different fission rates. It could be that they are in a particular cell type, which is in the lymph node and is less represented in other organs. But that is the future. We don't know yet.
Thank you.
Hello, my name is Irene Kasumba, and I'm also from University of Maryland. I just wanted to say that my talk tomorrow will be focusing on Salmonella serovars that we are typing from stool specimens collected during the Global Enteric Multicenter study. So you're all welcome.
That's what I like, somebody who's self-publicising it. Absolutely fantastic. Well done. So anybody else want to ask a question? Anybody from the panel? Otherwise, we will close this session. I'll give you a few more minutes. We've got somebody else, yeah?
Just a question aimed at Satheesh about the whole genome sequencing. You and I chatted about it. I think it's a great idea. Sorry, I'm Corin Ketty from the NICD in South Africa. But my understanding is that you've got a lag in your veterinary and agricultural surveillance program, so they haven't introduced it fully yet. So you haven't quite got to the point yet of tying in what's going on in the humans to tying in what's going on in your animal surveillance. And have you any idea yet how that's being addressed and when it's going to be introduced?
Thanks, Karen. That's a very good question. So when we started the whole genome sequencing project, basically, was based on the work that we carried out at Public Health England, where we looked at the human surveillance. And the animal guys basically have come on board, I think, the last 2 years. And right now we've got epidemiologists and people who are working within both institutions to try things up so that work is not duplicated. And I think this will happen in the next near future, but I can't give you a timeline, but hopefully soon, because I think we're just wasting a lot of resources. Two institutions trying to aim for the same goal, but working separately, which is not ideal. And I think hopefully in the next year or so, we'll see much better progress in that. But there's a lot of talks now between the two institutions. So yeah, that's all I can say at the moment.
Let's go ahead.
Hi, I'm Blanca from the University of Liverpool. I do have a question, but since we're advertising, I can't highlight enough how a good opportunity I'm offering here for sequencing your Salmonella strain, so please do come and talk to me. I'm in poster 62 and we can discuss it. Now the question. This is for Sandra, and I was wondering if you've seen any phenotypic differences between lineage 2 and lineage 2B, and also if you've tried any other animal model apart from mouse.
As a first thing, the phenotypic differences, so as I explained to you, the Salmonellas turned monophasic, so we confirmed this loss on the molecular level, but we also did motility experiments to look at the effects of that. And for the mice experiments, well, it's, as you know, probably a huge effort, because these experiments, they originate from 50 mice done in duplicates. So we are now running our 4th experiments of these mice, and it's IV inoculation and then counting the cell counts in spleen, blood, and liver. And in addition, we also did these macrophage experiments, and this was due because we know from the literature that we hypothesized that the flagellum as well could have an effect in these phenotypes. Well, we wanted to make a directed choice instead of screening for all possible animal models, of course.
Thank you.
Okay, it's great that we got some new questions. So I think we're just about there. I think we can now thank all the speakers. I think first of all, I'd like to thank them personally from myself and Ken for sticking absolutely to time. It's very easy. We were worried about it, but it's a very easy session. And we look forward to the next sessions this afternoon. Thank you very much.